Let me just once again, maybe we can close the door in back, as long as it's not a locked door. When we got here this morning, it was locked. I'd like once again to just acknowledge with an enormous amount of pleasure that this is the first Grand Rounds lecture in which the two campuses have been combined. I think this is the beginning of an extraordinarily fruitful period in the history of this department, and all of us look forward, I hope, to working together. And with that, I'll turn this over to Randy Glidden.
I'm really pleased to present you this morning Dr. Emilio Calabrese, who comes to us all the way from Italy, from Catania, Italy. He's a surgeon with specific interest in the organization of plans for the treatment of massive trauma emergencies. He graduated from the University of Catania in 1976 and then went to Stockholm, where he trained in the Department of Thoracic and Cardiovascular Surgery at the Karolinska Institute under Deacon Bjork. He then came to the United States and did complete residencies in general surgery and then cardiovascular surgery at the University of Medicine and Dentistry of New Jersey. Went back to Sicily after that, where he worked as a cardiovascular surgeon. He became a member of the faculty at New Jersey Medical School as a visiting assistant professor, and was then appointed chief civilian surgeon at the U.S. Naval Base Hospital in Sigonella, Sicily. He was director of surgery and director of medical education in Augusta Galaziotto Institute when this clinic was severely damaged by an earthquake. Because of the intensive preventive training that he had organized at that facility, casualties there were minimal. He's here today to share with us his experiences and ways they may be applied to our own hospital.
Thank you for inviting me, and I'll try to go down to the subject very fast because we are running a little bit late. Don't be worried about the fact that I will go very fast over some slides, but the subject is very complex, and I thought that could be better to stop our attention on certain subjects while we'll go very fast over some others. Okay, are you prepared for treatment of disaster, for handling the disaster in a hospital? Well, we don't know. We know that great part of hospitals in this country are prepared for what is called up to 1, 2, 3, or 4 levels of evacuation. But very few hospitals are able to do complete evacuation and handling of patients after that. As you know, you did a lot, let me see if I'm able to use this. You did a lot of exercise on the first, on the second, and maybe on the third level. Very rarely you do 4, almost never you do 5, what is called vertical out of the building. And we are going to be concerned only with vertical out of the building evacuation. And there are a lot of causes for this. We'll try to go through all of them very fast. A blackout is a possibility. Remember that in a blackout, you must be able to get out of the place, you must be able to see where you are going. What you are seeing now are slides of the damage that was done to our hospital in Sicily. Blackout. Emergency generator will protect you. A sterile generator are able to go on and provide light and electricity to equipment once you evacuated the hospital. But what you need is battery power lights. Remember, if in the middle of an operation, at about 6 or 7 p.m. in this hospital, the power goes out and the emergency generator doesn't work, this hospital is completely in complete darkness. The only kind of light you have in this hospital are laryngoscope, ophthalmoscope, otoscope, and maybe the neurologist will have some lights. That's all you have. This is extremely dangerous. Simple battery power light should be distributed everywhere. And also, what worries me a lot is the fact that staircases have absolutely no emergency lighting in this hospital, except for the one that is controlled by emergency generators that may fail. Okay, battery power equipment is needed because once something goes off. Once you have no electricity by any means, you do need to run certain machines. And we'll see which one we can run and how we can run them. I'll try to be very practical because otherwise we'll fall asleep at 7 o'clock in the morning. Okay, how many generators you have? You have enough in this hospital. How is the maintenance? Seems very good. Full supply is very good. I went through all these things are very usual, so I don't want to make you lose much time. You're doing scheduled checks. But be careful. After you do maintenance, after you try the machine for some time, you must check the full supply at the end of the control. Because you may burn a lot of it just by doing checks. Transfer switches are the ones that let you enable the activation of this generator. You must be able that they work. You must be sure that they work, that you can activate them manually. Reciprocal linkage. This is the problem that probably you never had. But remember that one of the generators can go sour. You may have only one. Another hospital may have only one. Some hospitals are linked in between each other, so they can use each other's generator in case of a big problem. This is probably not the need in this hospital because there's so many of them. Luvers control, very important. This is a catastrophe that happened in Canada. Practically, these generators have an air intake and a ventilation system that depends on these louvers, little things that turn over and let air go in and out. But they are electrically moved. If something happened to the connection, they will stay closed. The generator will start working within minutes, and that's it. So you must be sure you know how the louvers open, and you must make sure that if something happens to electricity, louvers stay open. Otherwise, you may have as many generators as they want. They may all stop. Okay, be careful how generators are set up, because the suspension system made them very vulnerable in case of an earthquake or in certain type of explosion. They must be restrained. Your generator are not very well restrained, so something should be done about it. Batteries, positioning batteries restrained is another problem. This is your generator, typical generator. These are the batteries. Here the louvers are. These batteries, as you see, are just put on the floor. If there's a water problem here, this battery will stop working. So the generator will stop working. It will never start. If there's an earthquake, this battery will go away, they will cut off the wire, and the generator will never start. It costs about $10 to fix these batteries with a Beth. It should be done. Otherwise, you may have 10 generators, none, exactly none will work in case of an earthquake in this hospital. These are the louvers. I don't have an answer yet as on the way louvers work, if they stay open in case of an emergency, but you go to it. This is the bolt that restrains the generator to the suspension system. We do not know the specification of the bolt. It may be too little. And the generator will go away in case of a big earthquake or even a middle one. Okay, you need a cellular generator. I don't want you to lose time on this very much. And you need to run away of this hospital by some means. The problem are elevators. We were told that you don't use elevator when you have a fire, you don't use elevator when you have an earthquake. Well, the problem is getting out so many patients that are bedridden without elevator is a problem. So sometimes you must take the chance and use the elevator. The problem is that, especially in this country, many elevators have what is called the motion control. If there was too much motion, they're shut off, period. So you must make sure that your hospital has a system so that you can reactivate elevators in case they've been blocked by the motion control. And now we go much faster. These are the staircases, okay? You need lighting. And remember, it's so difficult to get a patient down the staircase. It's almost impossible because you will hurt them a lot. Mattresses are very difficult to put down very usual staircases because the turnaround is very small. You will not be able to get a patient down. I had an incredible experience in Augusta because we had to carry all these patients out. It's the same problem you will have. At one point you have no more stretcher, you have nothing else. So you have to carry them down the stair. And if you carry them with a blanket, of course it will hurt because they will do like this all the way. and in fact we had an episode in which the wife of a patient that was helping to evacuate the guy had enough for him falling down continually, just pulled him down by the feet all the way to Florida. So you can solve this problem with slides, but I don't want to go through details. But remember, there's one staircase in this hospital that is absolutely dangerous. I saw it a couple of days ago. There are mirrors all the way here. They will disintegrate immediately, and they will pose great danger to anybody trying to evacuate staircases. They should be eliminated. It's even illegal, the position of a mirror in an emergency staircase. This is again August. As you see, you could see the lower floor as you were walking to evacuate patients. But you might be able to see where you are going. Okay, body power lighting, because you must see where you go. Your feet will go inside this hole. And then you have a problem. Another cause besides lack of light can be flooding. You don't have a problem in this hospital because besides having a basement, you have a sub-basement. This hospital probably gets flooded at least once or twice a year, like many other hospitals. But because you have this basement protection system, then you will not see the consequences of this. Because flooding is very dangerous. It gets light off from you, it gets suction off from you. So if you change hospital, make sure you know how things are. Water loss is a problem for almost everybody, but specifically for the renal dialysis unit. Fire is a problem for everybody. And remember that there are a lot of fires. Every year, 24,000 in this country, 24,000. Many are small, they are not reported, but there are so many of them, okay? A lot of evacuation in fire, but what you must know, in fire, patients very rarely get hurt, but doctors, nurses, and firefighters get hurt. And what is dangerous is the smoke more than the fire. The fire gets confined very fast. Transportation. Remember, you may have problem en route from transportation, and so you must be able to go over it, you must be able to see. Another problem, and we're going to stop more on it, is explosion. There are many reasons to get an explosion in the hospital. It can be accidental, and you must know where dangerous areas are in the hospital. There can be sabotage. This is a very delicate subject. It's something about which you should discuss, because this is an ever-present problem. This is very difficult. We're coming in. We're coming in more. Now you enter. You go through. You are in the waiting area. You're in the waiting area. You are all familiar. This is an area of the waiting area. Sorry, it's upside down. And you open up the door. That is always open. I went there many times. This door is always open. Anybody can do it in the waiting area. These are vital pipelines to the hospital. All electrical system to the upper floor, probably to the operating room, probably to the ICU, goes through these lines. This is the room. Anybody can enter this room. There are switches that will block the elevator, and specifically all this line. How simple it is? You just need a little can of gasoline, and you put fire, you leave, the can will explode, and the whole hospital will have a fire and no electricity, and no backup system. It's so simple to solve this problem, just to the law. So, you must check the entrance to the building. Remember, police can do very little for you. Have the key areas protected, and this is one of the key areas, besides the oxygen supply system and so on. Vital lines, like this electrical line going up, have to be protected, and vital equipment need to be protected. But we don't work through more. Police can do something, but remember, protecting this area is not essential, because an explosion in this area can do very little damage. An explosion inside the hospital can do a lot of damage. And you can go with a car right inside the hospital. And you know this has happened in Lebanon, this has happened in other places. All you need to do is put a little flower pot made of reinforced concrete in front of the entrance of the hospital. You will not block the entrance of the hospital, but you will block any big car, any big vehicle from going straight inside your waiting area. Okay, what are the problems with explosion? Bodily damage is death is a problem, but we're not really concerned with that. The pathologist is, we can do not much about it. But bodily damage is a problem. More than bodily damage of the people near the explosion is fire is an explosion in a vital area. Structural damage doesn't mean that the whole building will fall down, but means that vital structure, that a part of the building can be damaged. Okay, there are many ways to treat victims of explosion. One is scoop and run. That's the technique that is used in certain war theater and in England. That is, you get a patient and get him to the nearest hospital or to the upper floor of the hospital. And the other one is triage stabilize. That's used only in France. And people go there and try to stabilize it to the maximum for the patient where it is and then move on. A word about the explosion. The problem with explosion when you have one is to see the patient, see what kind of damage they have, and always look at the eardrums. Take a otoscope and look at them. Because if the eardrums are damaged, there may be a good chance that the lung is damaged with blast injury, and you may not know it. There may be no symptom for a while until they die. So it's essential that you look at the eardrum, and an eardrum that is broken is an alarm signal for you. Okay, contamination is a possibility, yes, but a couple of radioactive sources because you irradiate the blood of relative donors and children. And this is your little machine, but we'll not go through that today because there's not enough time. And earthquake is a combination of all the disasters that can happen in this hospital. It can be a fire, it can be a water leak, it can be loss of water, it can be structural damage, it can be explosion, it can be anything. And besides, you may not be able to get outside help. At that time, those were totally isolated. The old earthquake did a lot of damage in Sicily and in Greece, and this is why these temples are in this condition. And this is an American hospital, and this is what they were trying to evacuate patients with, but there was no chance. And this is America. The highest risk area is the part of California, part of Alaska. These are the second high risk. And of course, Boston is there. There's a very good possibility that you can get a major earthquake in Boston. And it may not be just an earthquake. Probably because of the ground where this hospital and other things are built. There are other kinds of dangers that may resemble a localized earthquake. And it should be treated as such. Okay. When you have an earthquake, 1/3 of the death may happen inside hospitals. So remember, most of the death in an earthquake may happen inside your hospital because of the kind of population you have and because of a characteristic of the hospital. That is, the non-structural part of the hospital is very dangerous. That is, for example, the ventilator that moves and disconnects from patient, the TV that will fall on the head of a patient, and so on. Okay. Also, a hospital, I got it, a structure that have been staying on for a long time. This hospital is a typical place. You have the little building, then you put another one, then you put another one, then you put another one, then you put a floor up there, and so on. For example, all the lower part of this hospital is not earthquake resistant because it's built before 1975. But X-ray department and the cesium machine that sterilize or anyway irradiate the blood bank blood are very reinforced. So in case of an earthquake, you will get the X-ray department down on the ground floor. And probably your radioactive machine will go all the way down, wherever is needed. Now, complex non-structural dangerous items are a problem in any hospital. In a hospital in Udine, in Italy, there was a very strong earthquake. And this terminated almost all patients in the ICU. These patients were connected to all ventilators that are called Engstrom. They're very big ventilators. It was several years ago. And in earthquake, the heavier the object, the more force you get in moving. You cannot stop it. Okay, and so practically this ventilator moved, extubated the patient, crushed some of the nurses, and did a lot of damage because they were not restrained. That hospital was in very, very high risk for earthquake. Also, no hospital does level 5 drills. Probably you never did one here. This is again my clinic in Augusta, the day after. This is structural damage. The main beam, reinforced concrete, was damaged and bent, and the electrical system was out. Still, because the emergency power supply was built with a special earthquake-resistant technique that we supervised, we still got electrical lighting. That was important during evacuation. Look at this building. It's very interesting. This is an American hospital after an earthquake. Very little damage, right? Not much. The problem is that this was a 2-floor hospital the day before. And this was inside that hospital. This looks like a bayonet. Again, this is Augusta. You could see outside, and the patients were complaining because it was cold and they want the window closed that night. Okay, so everything will fail. In the hospital, around the hospital, inside the brain of people. Has a lot of damage. Electricity. If the external supply will fail, you have the internal generator taking on. The internal generator will fail. You must have battery light. This is exactly what you don't have in this hospital. It's very cheap to buy them. It's the only way to run out of this hospital in case of an emergency. You have no other way. Coming down 10 floors with no light is impossible. I think the United States should learn from the experience of the World Trade Center. Total darkness is a very dangerous thing. And a battery light costs a few dollars, I think. So when battery lights are out, because eventually they will be out, there will be a external generator arriving outside. And of course there will be no heating, and then you have blanket and tents, or maybe water bottles. Water failure. Main water supply, you have reservoirs. In this hospital you don't have reservoirs. So you may have to use water canisters to carry this water or whatever, some tanks. You will need purified water, and they are portable unit, because dialysis relies on purified water. Why dialysis is so important? Of all the units, the most important one in an earthquake is dialysis unit, beside anesthesia and surgery. And you'll see why. You may use portable unit, eventually they will not be usable anymore. The National Guard has special purification units available. Okay, they use it in Alabama in a case of an emergency in Des Moines. Okay, communication failure. Internal phone usually work. You can communicate inside the hospital. But remember, if there's been an explosion, people they have damage to the tympanic membrane in that area, you may not be able to communicate with them that easily. You may ring call on the phone and get no answer. External phones can be replaced by cellular phone. Cellular phones can be replaced by CB radio. This is CB radio, this is a mistake. Can be replaced by messengers. Don't think you can rely on cellular phone, because in case of an earthquake or even in case of an explosion, everybody will get on a cellular phone to communicate if they do have. In Italy, everybody has a cellular phone, so you cannot use it in an emergency because the line will get clogged, completely clogged. Also, the antennas can be damaged any place, so you may not be able to communicate. CB radio is a very good way. Eventually messengers are a very good way. How messengers should go? Do not, never dispatch anybody by car. It's a nonsense in any kind of earthquake to dispatch anybody by car. Okay, internal phone can be replaced by security radio if they fail, and security radio by written messages that go up and down. Route transportation must be only by foot, bike, or motorcycle. Any other transportation is totally wrong. Do we have bike in this hospital? Probably not a single one. And the fuel bike can do a lot of help in a situation like that. This is the kind of structural damage that had the wall, the external wall. Inside this, there was the operating room where we were doing a case in that moment. And this is what happened. Of course, the internal line in this hospital were damaged. Okay. The structural failure of the building is important because it tells you if you need to evacuate completely. This looks like a familiar place to you. You must know where to go if you get out of the hospital. And this is a good place. Maybe this is a good place. Maybe this is a good place. This is certainly a good place. You need two places. Remember, when you have a lot of damage, you need to get this patient out of here and somewhere else. And you cannot do it with a small helicopter. You need big twin rotors helicopter, and they do a lot of damage if they land beside patients. So you need a lot of space and possibly two spaces. Look at this building, it's bent. And probably you can do nothing for it. And you remember it, one floor down. It looks compact now. Again, our clinic in Augusta, no outside windows, and these are the beds, and you need to get the patient out of this. Some of the patients were under the rubble. Next. I'm going very fast, then I'll try to stop in a few seconds because we're going to approach specific problem to anesthesia. But I thought it would be interesting for you to see more or less something of everything, to have an idea of how complex is the problem. Okay, behavioral problem. There are behavioral problem among the patient, there are behavioral problem among the nurses, there are behavioral problem among the doctors. One thing, and this is important for you to know, that has been found in many earthquakes, and we found in Augusta, is we have doctor and nurses inside the hospital that will do help, but they will be worried about their families. And it's very difficult that you will get any doctor or nurse from outside before he knows that his family is safe. So if you want to rely on an efficient system, you must make sure that each person that is part of this efficient system and that should be called in from home as a system for safety keeping of his family. Otherwise you will have a problem. And this has been seen many times, and we saw it in Augusta. We got no outside help for about 1.5 hours. Then all the doctors of the clinic came in. They came with their families. So they made sure they collected all the families before they came to help. We will not talk about psych assistance. You know, this is a subject unless you have specific questions. What do surgeons do? Bleeding control, amputation, fasciotomies. These are the most commonly done operation. Chest tube insertion, multiple rolls. The problem is the surgeon may become anesthesiologist and the anesthesiologist may become surgeon, depending how many of them are available. So, you know how surgeons are. We better give them a way to do very, very simplified anesthesia. This is radiology. Abdominal ultrasound they may have to do. It will help. Maybe they will have no electricity because CT scan will go. They will not be able to use it. Portable X-ray, you need them downstairs. They have one on this floor, on the ground floor. It runs on batteries for several X-rays possibilities. And so you have some help. Multiple roles. Radiologists are a little bit refractory to multiple roles. We had a big accident at a Hyatt hotel in this country many years ago, and there was a lot of criticism because they were having a conventional radiologist there, and the first aid to the victim in that place was not really perfect. And medicine, well, they have a lot of problems to deal with. Respiratory problem is very important. Remember, explosion and earthquake means dust. And it's not only dust, it's dust mixed with chemical fumes, with anything. So you will get a lot of bronchospasm in a lot of people. They found out that one of the most used medication are sprays, respiratory like albuterol, stuff like that. So this is respiratory problem are a big problem. Cardiac emergencies, usually you don't do CPR in this situation. If you are in cardiac arrest in an earthquake, you may be a little bit out of luck because the triage system is quite different. There are too many people at risk. The possibility of rescuing people who are in cardiac arrest from trauma, from crashing or anything are so little that usually you need to dedicate your attention to other people. Usually, depends on the situation. Hypertension, diabetes will be a big problem for them. And multiple roles. Well, we have to think about medical people doing operation. And nephrology, very, very important service. Because what kills people in an earthquake is, one, immediate death, that is, they get crushed, and again, we don't get involved with that. We can do nothing for people who die immediately, okay? And the second thing is renal failure and hyperkalemia. Because they get crushed, they get rhabdomyolysis, they get myoglobinuria, they get hyperkalemia, they get hypocalcemia, and they really have a lot of problems. So dialysis, or anyway, the nephrology department work is very, very important. And I think anesthesia should consider their problem, because much of what anesthesia will do will determine what will be the future of that patient. And we saw this in the Lebanon episode when, you know, they had a bomb explode inside of the Marines building some time ago. Okay, nephrology has to deal with a chronic patient. Well, they get them off and they send them somewhere else if they can. With acute patient, but especially they have to deal with rhabdomyolysis, myoglobinuria, hyperkalemia, with the lack of water supply, with the quality of the water they have, with the lack of electricity, a lot of problems. Now, they demonstrated that filling up the patient to the maximum possible in the first few hours will prevent renal failure in the great majority. Some people advocated, in fact they did it in Beirut, to put a CPP line and force fluid as much as it can be tolerated, risking pulmonary edema, and this reduced to almost zero the incidence of renal failure in the people in Beirut. Remember, they were young people, that's the difference, okay? So vigorous hydration is important. You must alkalinize the urine. This patient must receive bicarbonate. The reason is myoglobin will go straight into the tubules, will precipitate, form cylinder, cast, and clog. And usually it tends to stay more in solution if you don't have acid urine. Fasciotomy may be needed, dialysis, and then continuous arteriovenous hemofiltration is a possibility because it doesn't need electricity, it doesn't need very much. Some people add dialysis to that. The Russian advocate the use of hyperbaric chamber. We had it in Augusta, of course. We would even consider using it in a case like this. You don't put a patient after an earthquake in an hyperbaric chamber. There is a very delicate system with a lot of tubing. You are lost if you have a second earthquake with a patient inside. Forget it. And neurosurgery has a high immediate mortality, and we will not deal very much with this, and they do really need a tertiary care center to do anything. Mental health would be a problem, and it will be a problem for doctors for several months to come. Anybody that was in the earthquake in Augusta had nightmares. All of us did. I used to sleep with a helmet for a week or two after the earthquake. Pharmacy needs to have a lot of drugs available, and I just want to point you to a drug that they don't have available very much. That's ketamine. The lab. The lab has no water, no electricity, but you want lab. You need ABG, you need potassium, you need glucose, you need hemoglobin. You need them, and you need them outside in the hospital. No problem. There's a machine that does it. Very simple. Each test costs $9. This machine is battery operated. It's made in New Jersey. Apparently, I knew it was made in Princeton. This is the way we had it in Italy. But apparently, they make it in Canada, and the company in Princeton commercializes it. This is so good. It's good to have an ICU. It's good to have any place. Battery operator will do blood gas, will do calcium, will do potassium, will do hemoglobin, will do anything. No water, no electricity needed. Medical equipment, diagnostic. Don't forget the otoscope. The AC is the machine you just saw. Portable medical equipment, okay? You know more or less what they need. And this is a machine that you may need. You're probably accustomed to use very complex, well, this is a backpack. I don't want to go through this. It's the system they use for medication. Okay. Anesthesia in the field. You're doing anesthesia to people with a full stomach, no ventilator available, very little assistance, reduced personnel. You are scared because you're in the middle of the building and it's still falling on you. There may be a secondary earthquake coming. You're working with volunteers, and many of them may not know what to do. I have a few minutes more.
Absolutely, go ahead.
Okay. So you need to change the way you do anesthesia. This is a beautiful ventilator, but the problem with the servo of all ventilators is that it needs a certain relationship between the air intake pressure and the oxygen intake pressure. If you have too much difference, it will stop working properly. The Bennett will work. The servo will stop. And you really cannot have such delicacies in an earthquake. In fact, you may not have any electricity, so this will not work. So you may go back to either anesthesia, but that's dangerous because you may have fire camps, you may have anything going on, so that's impossible to do. And you have to find a way for ventilators, and this is a good way. Ambu bag are good, but ambu bag will tie up a person completely. As you know, we have, you know all this, but I'll go through very fast. Volume control, all time control ventilator, pressure control ventilator, high frequency ventilator, jet, pneumatic, high frequency oscillators. Now, this is a pressure control ventilator. It will deliver air to the patient until a certain pressure is reached, then expiration will start. It's driven only by an oxygen tank. It may deliver either 60% oxygen or 100% oxygen, either or. You have no other alternative with the beer, with this beer. Unless you make it complicated with flow meters and so on, but you don't want to deal with that. So this is a machine that probably many people should be able to use. A time control ventilator mixed with jet ventilator are another way. Remember that if you push with a pistol oxygen at high pressure through a jet system inside the trachea, you can temporarily ventilate a patient. It's a very dangerous way of doing it, but depends how desperate you are, how much fracture you have, and what kind of stuff you have to do a tracheostomy or to ventilate, how many ambu bags you have in a hospital. I heard that there was a prominent hospital in this town that didn't have enough ambu bags for all its patients when the electricity went off. So you have to consider that possibility. Okay, why ketamine for anesthesia? Well, ketamine has certain advantages. You can give it with no need for ET intubation. You keep spontaneous respiration, rarely respiratory depression. These people have been eating, so somehow you protect their way. Of course, intubation is the best protection when you can get all of it. It's very rare significant laryngospasm, and also is very good in relieving bronchospasm. That is a very common occurrence because of the dust, contaminated dust. There are problems. The emergence phenomenon, we all know, when the patient gets up, wakes up, they can get any kind of psychotic behavior. You can treat it with benzodiazepine, or may just do nothing in a case like that. Elevation intracranial pressure, well, this is well documented, and the problem is that some of them have head trauma, so probably those one may need to be evaluated by the anesthesiologist and decide what to do about that. Myoclonus is a problem. You get a myoclonus and you get nystagmus with ketamine. So if you have a ruptured eyeball, ketamine may not be the right thing to do for transportation of the patient, for control of pain, or for any kind of anesthesia, because the whole content of the eye globe can come out and you get a real problem for the patient you cannot reverse. So you must know about this problem. Skeletal muscle hypertonia rigidity is not a big deal. Increase of pulmonary artery pressure, we know that, so people who have chronic pulmonary disease probably are not the best candidate for ketamine. There are some cardiovascular effects, and again, you all know them, and transient ataxia is a problem, we don't care, this patient cannot walk right after ketamine, you know, we don't expect them to walk away from the place. I've been collected studies in 11,000 patients, and the problem is how the ketamine behave when patients had just eaten an hour before, in fact, because it was an hour before or more than 6 hours, and there was no big incidence of vomiting in the group of people who had just been eating. What this means, very little, but again, it just encourages you to say, I could use ketamine. Some problem is salivation, rarely laryngospasm, of course aspiration, like in any kind of anesthesia. Respiratory depression is very rare. Emergence phenomena is the thing that we are always concerned about. And the risk factors are when people are more than 10 years. In fact, the critical age is 10 to 16 years. Probably, they dream of funny stuff, and it comes up when, you give this ketamine. Female are more sensitive to the problem. When you do rapid IV administration, and here comes a subject to discuss, when there's excessive noise during recovery, of course you will have it. Where you have prior personality disorder, if schizoid personality get ketamine, you will have a problem. But you may have a problem identifying who is. More common problem with IV than IM route. Many of you will say, well, why should I use IM route for ketamine? Well, you don't know who's giving anesthesia, who's giving ketamine. You may not be enough. There may not be enough for you to give all the anesthesia in the field. There are some contraindications, and in fact, of those 11,000 people, the one that got problems, serious problems, were small children, and people with active pulmonary infection. Okay, you can give it IV, you can give it IM, you can give it IV continuous. Well, IV continuous is a better way if you can do it in an earthquake or in a serious emergency. But probably you can do it after an explosion because you don't have so many people damaged. You have enough anesthesiologists to organize this, and you still have some battery-operated pumps. Don't forget your relationship with the media. You think it's a little thing, but it's very, very important. You must have somebody that keeps relationship with a journalist. You must be precise because they need you, but you need them more. This is the clinic how we look after the first earthquake, right? We had those patients. They wanted to know, the family wanted to know what happened to this guy. In fact, this guy was a young boy who had osteomyelitis, and he had been undergoing months of antibiotic treatment, hyperbaric chamber, and anything curettage, and so eventually healed. He was ready for discharge. This fell on him and broke his bone. When you told the media, this is what you need. Single overriding communication objective. This means the media is asking you a question, you will answer to them, but you must make sure they understand what you need. You have to go back to what you need. Rebuilding the hospital, more help, volunteer, money, ambulance, radio control, telephone help, water, anything else. The media can help you a lot because television and radio network are much more efficient than any of your telephone system. And from here, well, I don't see very much. I don't know why I don't see very much, but anyway, this is how the hospital in Augusta has been rebuilt. I don't know how to do this. I'm very bad. This is how it's been rebuilt. There's even a swimming pool here. This is the new earthquake-resistant building. This is the old building. And this is where arteriogram, nuclear magnetic resonance, and CT scan are kept. This is the helicopter landing pad. When we evacuated the people here, we put all the people on the helicopter landing pad. Very, very safe area in an earthquake, not in your hospital, because you have it on the roof. But on the ground, it's very safe. No earthquake can damage this unless it's really big. You have to be ready for this, for earthquake, for sabotage, for explosion, for any complete evacuation. I think this is enough because you'll fall asleep in a few seconds if I keep on talking. Thank you for your attention.
I think the last thing I want to do after hearing that talk is I feel really secure. Any questions for Dr. Calabrese? Chris?
Brandon, you mentioned there were minimal casualties. How many patients did you have in that hospital?
120 patients, mostly orthopedic and vascular cases. So this is a big load because the hospital is only a surgical hospital. This is only a department of surgery, the whole hospital. So 120 patients, many of them very difficult to evacuate. So we have to go up and down continuously to take this patient out. A big deal.
So what were your casualties? How many survived? Or...
Nobody died. There were 5 wounded patients. That's it. Remember that this clinic underwent intensive evacuation training for 2 years. Intensive evacuation training. People knew exactly what to do, where to go, how to evacuate patients. Everybody knew how to move. This was very, very, very important. And you saw how much damage was done. Nobody died. Of course, this is a matter of luck too, because depending where you get on your head.
Sarah?
Did you have any patients on ventilators?
In that moment, no. There was no patient on ventilator, no. No. We were having a patient under epidural being operated in the operating room. He was doing a femorotibial bypass in that moment, and we concluded the operation within seconds because we thought that there was no help for him because the operating table went moving around. The patient was a little bit scared. And I left the operating room because I had to assist the evacuation and to coordinate it. So my first assistant stayed in there asking about his wife who was at home in a very old building and closed the wound so fast you wouldn't believe it. And we threw this patient in the garden in the middle of December. Remember, microvascular patient had heating blanket, circulation water. We had spiral heated IV lines. We had complete dilatation with the epidural, and we put him almost into the snow. There's no snow in Sicily, but it was about 35 Fahrenheit. He went into shock immediately. He survived though.
I wonder if Rob Lecky, who's the chairman of the Disaster Committee, has any comments.
Well, several actually. I think this is a very well-timed talk because the Longwood area is going to start working on their joint evacuation plans very shortly. And clearly up to this point we've had some things in place. A lot of planning goes on that people don't really know about. The things are in place to evacuate parts are all in the building, but every time we get a plan in place, then you build a new building, and we have to start over again. I didn't know this when I first started working on the disaster committee with Boston. I think it's ranked number 7 in the United States for possible targets for terrorist attack. I think when we get the Super Bowl champions here, that number will probably change. Some of the
Have any concerns?
Some of the terrorist-related activities that we're going to be looking at shortly are not just explosions, but contamination. There's going to be a drill shortly where someone drops a load of anthrax at Logan Airport that spreads all through the city. So that's going to be an interesting drill we're going to do. We do have a lot of things in place as far as water replacement, and our backup generators are among the best in the city. I invite anybody who's interested to sit in on the disaster committee. It's a very educational, informative, lively group. Lee Bancroft is involved up in series, as you can imagine. And if anyone wants to get in touch with me and be involved, it'd be great.
Anything else? Thank you.
Thank you very much. I hope my English was clear enough.
Shaking.